All right, so yeah, I'll be talking about this line of research using psilocybin to treat. Oh yeah, thank you. So that's cool because I don't have the whole. Instructions. There we go. Okay, so I'll describe this line of research examining psilocybin as a treatment for tobacco addiction. And so by way of disclosures, let's see, is that advancing here? There it works. So I've advised as a consultant several companies developing psychedelics as medicines, but none of what I'm presenting today is directly related to these entities. So as most of you probably know, psilocybin is the active agent in over 100 species of mushrooms. Pharmacologically, it's a serotonin 2A agonist, which we refer to as classic psychedelics. In that same category is LSD, mescaline, and dimethyltryptamine. And there I'm showing you some psilocybin in the form of Psilocybe cubensis species. Photo thanks to mushroom expert Paul Stamets. Psilocybin's use is ancient, apparently. I'm showing you examples from several hundred to a few thousand years ago from Meso and South America, but on the right, the oldest example suggesting sacramental use dates back to an estimated 9,000 years ago. This was a cave painting in northern Africa, so Algeria, and I don't know if you can see it well, but you have several little characters whose heads are giant mushrooms, and they're holding mushrooms in their hands. And it may be just me, but I kind of look at that, and I tend to see, if you're familiar with the Grateful Dead bears that are dancing in unison, not dissimilar. So, suggestive of some type of perhaps sacramental use. But then fast forwarding several millennia, we get to this earlier era of psychedelic research from the 40s through the 70s, where psychedelics were intensely investigated as both research tools and as therapeutics. And I'd say the most promising clinical findings were treating end-of-life cancer patients and treatment of alcoholism. And this was mainly with LSD. And then we get to what I call the dark ages. So you can see this poor researcher hanging from the town square because perhaps of his psychedelic research. But it's important to note that despite these promising findings, there was a decades-long dormancy. And why was this? There were some very real casualties. So particularly LSD became very popular in young people in the mid to late 1960s. And I always remind folks the doses of LSD that were being used were about 6 times higher than those today, based on seized samples. So there were some casualties, including people who had psychiatric vulnerabilities and people that were just using in an unsafe way and reckless situations. But probably more important to the backlash was this association with the counterculture. So many of the changes in society in the 1960s, the psychedelics were associated with the anti-war movement and many of the various civil rights movements. And those changes scared a lot of people, and lots of stuff came out quickly. In the 1970s, it was unearthed that the US CIA was conducting clandestine research with psychedelics, including dosing American citizens without their knowledge or consent. So it kind of shifted pretty quickly from being like really exciting in research domains and even in the broader public to getting a very negative connotation. Also, there were the Manson murders at the end of the 1960s. Charles Manson had used LSD as one way to brainwash his cult followers and ended up committing some pretty famous murders. So a whole lot have happened really quickly to kind of taint the public image of psychedelics. And unfortunately, the research was the casualty. There was some reckless research and some unethical research, but there was a lot of really good research that was done ethically that was unfortunately sacrificed for a few decades. So this is I'm graphing here the yearly hits on PubMed for research papers with either psychedelic or hallucinogen in the title or in the abstract. And this just demonstrates that, for years, this goes back to 1980, there's a pretty steady baseline of 5, 10, 20 papers a year, pretty mild, scientific interest. And I was lucky to get in the field in 2004, back when you could actually say I was on top of the scientific literature, which is impossible today. Like, you could read everything that had come out this year on psychedelics. And so now there's just this exponential-like increase in scientific interest. And even though much of this is, non-human work, and it's mechanistic work, and chemistry, and all kinds of other things, I would say the reason for the increased interest, even in all of those areas, are primarily driven by some of the exciting clinical therapeutic findings. So I always like to, if I'm talking about psychedelics, to mention that these are powerful agents. They do have a downside. So I've published some papers in the field here in 2008 and 2018 reviewing the various risks and how we should deal with them in research and how we potentially should deal with them in regulation if they're approved as medicines. I won't go over all of this because of time, but the two big risks are the first two, that it does appear that these psychedelics can harm people that have either active psychotic disease or an identifiable predisposition for psychosis. And the second one is what we call the bad trip. So in anyone at a high enough dose, no matter how healthy, could have a period of very strong panic, fear, anxiety, that could lead and sometimes does lead to dangerous behavior and some harms. And rarely, but it's reality, it has happened. Sometimes people have fatal accidents, as they do with any intoxicating substance, particularly in an unsafe environment. The last harm is on the list is one that is not there for psychedelics. So unlike really all other classes of drugs of abuse, the classic psychedelics apparently don't have addiction potential. That isn't to say they don't have abuse potential, meaning they can be used in dangerous ways. They can cause harm, but they don't lead to compulsive drug seeking. And that's consistent with their mechanism or lack of mechanism in the mesolimbic dopamine system. It's consistent with epidemiology. It's consistent with animal models of operant reward, where you don't see animals responding for these as reinforcers. So that's useful to know, particularly as an addiction treatment. It's a bonus if your agent itself is not addictive. So psychedelic therapy, for those not aware, it's different than the typical psychiatric treatment paradigm. Rather than taking a pill every day to treat symptoms, it involves, I'm sorry, you may not be able to see that clearly, 1 to 3 medication sessions. And because of this limited number of sessions, they can be carefully monitored, including having medical professionals available should something untoward happen. The person is prepared. They're accompanied by someone, either a therapist or another professional that they've prepared with and have a rapport with. I'm showing you an example of a mock participant, so they could take the hand or otherwise verbally reassure them in case the person has some anxiety. And I mentioned there's preparation. There's also so-called integration, discussion of these experiences the day after or in subsequent sessions. So that's typically what we mean by psychedelic therapy, not just any taking of a psychedelic, but this particular treatment model of this time-limited exposure. And then this different paradigm, again, unlike traditional psychiatric medication, we're seeing improvements in symptoms, in some cases months, and sometimes even years later for various disorders. So perhaps more akin to surgery or more acute medical procedures that could have lasting impact rather than the typical taking a pill every day for symptom relief. And I would say that although certainly there are biological correlates and we have far more to learn about that, the other side of the coin in terms of this question, how could they have lasting benefit? I think the answer is that when someone is successfully treated, it sounds more like psychotherapy. And I would argue even when people have taken psychedelics recreationally, and I've done some survey research on this, and they say they've had some insightful experience that's benefited their life, it sounds like psychotherapeutic process, whether they're in nominal psychotherapy or not. In other words, people talk about having insights, taking a different perspective on themselves and their problems, being motivated to move in a new direction and form new patterns in their life. So again, very psychotherapy-like. And in that way, I think psychedelics, one of many reasons that they're interesting is they're kind of a way to bring psychology back into psychiatry. So it's not just about treating immediate symptoms with the pill, but to have a fuller psychological understanding and a way to biologically help people to deal with some of the psychological roots of their illness. So one of the early findings that I published with colleagues in healthy normals, so these are not patients with a disorder, but in healthy normals to investigate the effects of psychedelics in people. One of these findings that's consistent with anti-addiction potential is this study we published on personality openness. So this is combining two earlier studies on healthy normals receiving a high dose of psilocybin and characterizing the effects and the long-term effects of psilocybin. And by combining those data sets, we found that on average, people had an increase in one of the big 5 personality domains known as openness to experience, or openness for short. And what openness refers to is a tolerance for other people's points of views, the ability to take multiple perspectives at the same time, appreciation for aesthetics, art and other aesthetics. And so until this point, I'm not familiar with any other experimental intervention or discrete clinical intervention that you could schedule that had been shown to change a personality construct, which by definition, personality is relatively stable throughout someone's lifespan. So this was a notable finding. And I think openness is interesting in the context of addiction treatment, because part of addiction treatment is someone adopting a new point of view, thinking themselves differently, thinking of themselves no longer as a failure, because many times someone has tried to quit the substance many times and has been unsuccessful in the long term, so they can become very entrenched in thinking about themselves in a certain way. And notably, the effect was strong enough that it was statistically significant overall, but when you delved even further into the data, it appeared that the type of subjective experience that people had during the psilocybin session was actually a strong predictor of whether you had this increase in openness. So even though all of these were people received a high dose of psilocybin, at the bottom I'm showing, in the open circles, I'm showing people who, as measured at the end of the session day, people who did not fit criteria for a so-called complete mystical experience, and I'll explain that in a bit, did not show on average a change in personality openness, but that increase was driven by those people that did have a complete mystical experience. What do I mean by mystical experience? Well, it sounds very out there, very woo-woo, perhaps, but it's actually a psychological construct that goes back 100 years. William James first noted it. He and colleagues were interested in some of the commonalities across different extraordinary human experiences, not just prompted by drugs, but prompted by things like near-death experience, or prayer, or meditation, or sometimes just spontaneously, but that many of these extraordinary human experiences share these qualities of a sense of unity, such as all of the universe, you're feeling at one with the universe, a positive mood, a sense of transcending the domains of time and space, and ineffability, which means that the person feels that the experience was beyond what words could possibly describe. And I've, with colleagues, published some psychometrically developed scales that have tried to do a better job at assessing this mystical experience. at the end of these sessions, including this one most recent version, the MEQ4, which is a brief measure that can measure it and with good correlation with the fuller version, 30-item version, fairly accurately. So that can be useful in future research. So you know, this openness, apparently driven in part by the mystical experience, perhaps, is one reason why we might suspect psychedelics to be able to treat addiction. Another reason is just this history of anthropological research in various indigenous societies and religions that have used psychedelics sacramentally. So there's this literature on addiction recovery, primarily with alcoholism, and by peyote use. Peyote contains mescaline within the Native American church, and there's also a literature on addiction recovery associated with ayahuasca use in South American religions and syncretic religions based on indigenous South American use of ayahuasca. Of course, those are correlational studies, and we also know that religious involvement itself can be associated with addiction recovery. So, you know, it's limited evidence, but it's suggestive. There's also those older studies I mentioned on LSD treatment of alcoholism, and that had been described as sort of a mixed bag of research. Some studies said there was a significant effect, others did not. It was hard to kind of make sense out of it, but over a decade ago, some researchers published a meta-analysis of the 6 studies, and there were only 6 studies that ever compared LSD to some other control condition in a randomized studies. And this is showing the results. This is improved odds of the odds ratio for improvement at the first follow-up, and the timing of that follow-up varied across the studies. But anything to the right of 1 is an odds ratio favoring the LSD group. The error bars represent 95% confidence interval. So the individual 6 studies are at the top. The large diamond is the aggregate. And what you're seeing here is, you know, the fact that those error bars overlap in some cases with 1 is why in some cases the original study wasn't statistically significant. In some cases it was. In aggregate, there was a clear signal, a significant signal, but more notable than the statistical significance is the effect size, meaning an odds ratio of about 2, meaning people were essentially doubled their odds of success at the first follow-up, which is a very large treatment effect. There was also a study published with LSD in treating heroin addiction, published in the early 70s. And there were some limitations, you know, like these other studies, it wasn't blinded. In this study, there was a brief inpatient stay the LSD patients had that the others did not. But there were some strengths. There was biological confirmation of drug abstinence, which wasn't common in the day. And they had long-term follow-up. So they found like this group that received LSD treatment had substantially lower, or I should say substantially higher abstinent rates 12 months after LSD treatment compared to the control condition. So that, you know, with some of these signals across different drugs of abuse, including alcohol and opioids, and also combined with other anecdotes I haven't mentioned across many different drugs, that these addiction recovery stories. With colleagues, I was inspired to investigate tobacco smoking, which is kind of interesting. In some sense, it's a pure form of addiction, perhaps, in the sense that there is certainly the self-control issue, but you also don't have the life destruction that you get with most other substances, potentially. And so, you know, does it only work for something like heavy alcoholism, where people have these rock bottom effects where they really destroyed their life, their spouse has left them, they've ruined their career, they've done all of these horrible things, or can it be leveraged towards more of a pure self-control issue like tobacco smoking, where there's a lot of people motivated to quit, but they can have a very difficult time overcoming that addiction. So first I'll describe this small pilot study we published a decade ago now, and started a number of years before that, but it was a small open label single group where we had 15 longtime smokers who had previously tried to quit. We used cognitive behavioral therapy, which is the standard, the most common psychotherapy to help people quit smoking, not in the psychedelic sessions themselves, which were conducted in that introspective framework where the person's lying on the couch, as I described, but the cognitive behavioral therapy was done in the preparation sessions on previous days to the drug administration and in the follow-up sessions, the so-called integration sessions. And yeah, the study got some coverage, which is always nice, in the press, but I have to say, hopefully you know by now that there are risks to psychedelics. I don't encourage these things in a blanket fashion. I'm not encouraging any drug use, but I have to especially emphasize, definitely don't take this many mushrooms, because they didn't check with me in that photo. If those are the real thing, that's a lot of mushrooms. The important things here were that these were long-term smokers. They weren't lightweights. They had been smoking on average over 30 years and smoked almost a pack of cigarettes a day. They all had multiple previous quit attempts. It was a 15-week protocol. As I mentioned, cognitive behavior therapy was used. There were 3 psilocybin sessions. That very first psilocybin session was on the same day that they were going to quit smoking, and that target quit date was assigned several weeks ahead of time. And we started at a moderate dose of, I would say moderately high dose of psilocybin, 20 milligrams per 70 kilograms. So it was adjusted by body weight. In my current research, I'm not adjusting for body weight. I think the evidence, we published a paper on this, doesn't suggest you really need to correct for body weight with psilocybin, but that's the way this one was conducted. And so I'll jump to the clinical results in this study. This is one of 2 biological metrics to verify abstinence in this study. So this is exhaled breath carbon monoxide. So it's a reliable indicator of whether someone's been smoking over approximately the last 6 hours. And these are the median levels before the first psilocybin session, and these are the levels after. I'm showing you with the vertical line, the psilocybin, the first psilocybin session, and that horizontal dotted line is our threshold for determining whether the levels were indicating recent smoking or not. So clearly there was a pre-post effect here. Another way to look at that is point prevalence abstinence. This is one of the ways to look at smoking cessation research. It means that both self-report and the biological verification is consistent with not having smoked within the last week. So if you had, started smoking again, but now you've been quit at least a week, you would be considered abstinent. And so at 6 months, this was 80% were abstinent. And then at 30 months, which is 2.5 years, we had a very long-term follow-up. We found that 60% of people were still abstinent, which are very high rates. It was a small pilot, so we had to be guarded in terms of making any causal attribution, but it was a very promising finding for follow-up because these are very high levels. So I say take this with a grain of salt because I am drawing from normative data drawn from different sources, but I've tried to get the most representative data for the typical treatment abstinence levels for different treatments, including medications like varenicline, bupropion, nicotine replacement therapy, cognitive behavioral therapy by itself. And you can see on the right, these are our results. I'm actually showing you a slightly different metric on the y-axis, not 7 to 8 point prevalence abstinence, but continuous abstinence. This is the most stringent measure. This means since the target quit date, you haven't had a single puff on a cigarette. It's overly restrictive, but it's one way to look at the data. But over 50% in our sample, and so again, very high rates. It definitely told us it was worthy to follow up on this. We also conducted qualitative interviews with these people at that 2.5-year follow-up, and we asked people if we thought the psilocybin helped them quit, and if so, how it helped them quit. So these are the themes that were mentioned by multiple participants. One, that it provided a persisting sense of interconnectedness, awe, and curiosity. They said that it would reduce smoking withdrawal symptoms. They said that they had Other positive changes, increases in altruism, appreciation for aesthetics. That's consistent with the openness finding I mentioned earlier. They said there were idiosyncratic personal insights into self-identity, kind of their personal narrative surrounding smoking. They felt that they had sort of had some psychological resolution over their reasons for smoking. And here are some quotes that we published in that study. In this one, they said, I understood my identity as a construct. I'm more grateful. I was given lessons about what to do so I don't get so depressed, which is interesting given that the other work suggesting psilocybin is effective in treating depression. Seeing life as an unspeakably marvelous adventure of existence, more accepting of myself. And so the one thing to note from these particular example, sometimes people, of course, mention specific things about smoking, but none of this is nominally about smoking. So these were very, big experiences for people. People would routinely say at the follow-up, the study was about so much more than smoking. And so we try to warn people about this. You can't control what your psychedelic experience is going to be like. But nonetheless, people felt that the experience that they leveraged it towards, being able to more easily quit smoking. We did find, like some other research we had done in cancer patients with depression and anxiety, we found here that stronger measures of mystical experience, which I described, at the end of the session day showed some relationship to long-term improvements, in this case, lower craving scores for cigarettes. So consistent with some other work suggesting that mystical experience is at least correlated with treatment success. So then when it was time for the next step in this line of research, some of the issues that we kind of thought about was this blinding issue for psychedelics. So this has been the source of a lot of discussion and controversy, this idea that it may be impossible to completely have a credible blind. In other words, in a placebo-controlled trial, can you really fool someone into not knowing whether they've had the real deal, the real psychedelic, or a placebo? Because it's going to be obvious once they've had the psychedelic. And it's a very complex issue that there may be no perfect solution from. I recently published, or a couple years ago, a review paper that looked at the entire history of control conditions in psychedelic research, and found one thing is that most studies, including some work that I've done, to admit that they didn't even assess the credibility of the blind. So we need to do a better job as a field in always assess. In other words, just simply asking someone after the trial, do you think you got the psilocybin or the placebo? But amongst those that did ask that type of question, 95% or more correctly guessed their condition. And when someone did give an incorrect guess, it was almost always in the direction of if they got the placebo, they thought they got the real thing. But almost never did you find once they got the real thing, they knew it wasn't a placebo. So it typically goes in that direction. So there are limits to it is a concern about the field, and there's no perfect way to address it. But the way for this next step that we decided to address it was really look at the science in a different way. So I think of, as a psychologist, I think of the science of behavioral treatments, the various psychotherapies that we have countless of, like cognitive behavioral therapy by itself, and the exposure-based therapies for phobias and anxiety disorders, PTSD, motivational enhancement therapy, dialectic behavior therapy, on and on. We have dozens of psychotherapies with mountains of science behind them. I would argue we know a lot scientifically validating these various empirically verified therapies, and virtually none of that is based on placebo-controlled research. And so let's conduct it like that. And what is the standard in that field of psychotherapy? Randomized comparative efficacy. Randomized people who are willing to do either the new thing of interest, the shiny new thing you're testing, or some known standard, and to track outcomes as objectively as possible, and you see whether you do just as well or better or worse than the known standard. And so we did that with psilocybin compared to nicotine patch treatment, one of the common forms of nicotine replacement therapy. So these were 82 treatment-resistant smokers. They either had psilocybin or a single session of psilocybin, and we scaled that down from our pilot study, which had 3 sessions. We kind of felt clinically that 2, we didn't find that for any of those 15 people that 3 was really necessary. It seemed like 2 was the sweet spot, but we actually scaled it back to 1, more for experimental reasons, because we're also doing, I don't have data from it yet, but we're doing pre and post fMRI imaging to look at correlates of treatment success, and it actually made the experiment way too complicated by having multiple psychedelic sessions. So we went with 1 session. Both groups had a similar cognitive behavioral therapy, the same therapy in each group, similar to what we had used in the pilot study. And like our pilot study, we probably the important thing is these were serious smokers. They smoked on average over 15 cigarettes a day, and they'd been smoking on average over a decade, high nicotine dependence scores. Like in the pilot study, we didn't have any serious adverse effects attributable to either psilocybin or the nicotine patch. In these studies, there's always adverse effects. They're typically, for a psychedelic study, anxiety and other acute effects when they're being clinically monitored, which are thankfully way easier to address than some side effect that comes out a week or a month later. So these are the abstinence data. I described what 7 to 8 point prevalence abstinence is. So at baseline, by definition, nobody is abstinent. At the 6-month follow-up, which we've now completed, 52% in the psilocybin group are biologically confirmed as abstinent, and that's compared to 25% in the nicotine patch group, which is on the upper end of typical efficacy rates based on the hundreds of studies that have been conducted on nicotine patch. So in the context of an open label randomized pilot, I think we did a really credible job with our control condition. But nonetheless, it's great to see that we doubled that success rate. The odds ratio is very high, over 3 times as likely to be successful if you were in the psilocybin group. I also described what continuous abstinence means. There hasn't been a single cigarette smoked since the target quit date. Again, a large difference there. That was 40% in the psilocybin group compared to 10% in the patch group. Even larger odds ratio on that outcome. Consistent with those clinical findings, I've also conducted some surveys of naturalistic addiction recovery stories in the context of addiction, not just for tobacco smoking, but also for alcohol, cocaine, methamphetamine, opioids, and cannabis. Just sort of collecting these stories of people, actually initially inspired when I was sharing my smoking research and talks like this early on. Sometimes I'd have people come up to me afterwards and say, oh yeah, like I used this whatever psychedelic a decade ago, and I just either quit drinking or I quit smoking, and so I thought, how many of these stories out there? Can we understand something from this landscape of these treatment recovery stories? And so I'll focus a little bit on that tobacco survey. So this was over 1,100 people said that they quit smoking or substantially reduced smoking following a psychedelic experience. And the large majority of these cases were people that had no therapeutic intent. They just took it at a festival or party or just with their friends out of curiosity or for fun. But nonetheless, they had this therapeutic-like outcome. And there's some evidence I'll show you suggesting that might be a commonality on the affective or the emotional symptoms, and which might be a commonality between how psychedelics are helping people with depression and also with addictive disorders. It could be an a beneficial effect on emotional regulation, which we know is an issue with both those classes of disorders. So when I asked people to compare the withdrawal symptoms when you quit or reduce smoking because of psilocybin compared to other times when you've tried to quit smoking, rate them on a Likert type scale of whether, it was the same, worse, or better than those other times you've quit smoking. And an interesting thing is that most of these symptoms, I would say, are more somatic symptoms, the large rectangle in the middle. And the modal response on these symptoms was that, it was about the same as other times I would try to quit smoking. But on the more affective symptoms, anxiety, restlessness, depression, low mood, irritability, craving, people said the modal response was not just less severe, but much less severe, really suggesting that there might be this particular aspect of withdrawal. And that, we know one of the reasons that smoking is beneficial is that people report enhancements of emotional regulation. So based on this data, I was lucky to get the first grant in the US since that earlier era in the 60s to do a therapeutic study with one of these classic psychedelics. Also, I'll show you a little bit of, and that study is going on right now. It's a multi-site study, but a very similar line of research, my colleague, Michael Bogenschutz, who's also the lead site in my multi-site tobacco trial that's currently undergoing, but he's conducted this line of research using psilocybin to treat alcohol use disorder. And a very similar, I'll describe it just very briefly, very similar trajectory is what I've described with tobacco. First, he published a small open label single group study with 10 alcohol dependent participants, 2 doses of psilocybin, found a large reduction in self-reported drinking days and heavy drinking days. And then he's followed up with a double-blind randomized trial. He used niacin, a high dose of niacin, which causes some flushing, as a so-called active control in this placebo-controlled trial. 2 sessions. He used motivational enhancement therapy. That's another form of psychotherapy that can be used towards treating alcohol use disorder. And he found, a significant effects favoring psilocybin compared to the blinded control in terms of significantly reducing the number of self-reported drinking days. He did have biological verification, which is harder to do with alcohol, but in a subset, I think it was 50 out of the 92 participants had an analysis of hair or fingernails for a particular protein associated, which is a marker of recent drinking within the last month or so. And that verified the abstinence claims. So I mentioned the multi-site trial. I don't have results yet. It's ongoing, but 66 people, 3 sites, the same, actually a more rigorously characterized form of CBT we're using in it, but it's 2 sessions, and this is a double-blind trial, so we're also using niacin as the active comparator. Not the perfect comparator, but it was the most feasible thing for getting it past the NIH reviewers and by having the FDA and the National Institute on Drug Abuse approve it. So probably not the perfect comparison, but it was the most feasible path forward. So current and future directions forward. So hopefully, fingers crossed, we've currently submitted the recent data I showed you from the comparative efficacy study, so we'll be publishing that. We also will be publishing before and after, I mentioned this, behavioral tasks and fMRI data to look at the correlates of treatment success. And we're looking at a number of things, including whether there's a change in resting state imaging in terms of brain network dynamics. We're also looking at various key reactivity tasks associated with smoking, executive function. Again, to look at the correlates of treatment success. We'll be looking at the subjective effects in relation, including mystical experience in relationship to successful outcomes. We're running that current multi-site trial that I mentioned. I'd really like to examine, I've been trying to get some funding to look at the role of psychotherapy. There was a really interesting commentary by Guy Goodwin at Oxford suggesting that psychotherapy is not necessary for this psychedelic treatment model, and it got all kinds of very strong opinions on this question. I think it's ultimately an empirical question. I do think it's ethically important to prepare people for these experiences and to provide interpersonal support during them for safety, but you could certainly conduct it with and without the nominal therapy, such as cognitive behavioral therapy. And I think this line of research is a perfect one to do that, because unlike some of the depression work, here we have a successful history of work suggesting that there is efficacy when we've used something like CBT, cognitive behavioral therapy. It would be great to look at a design where we compared outcomes with and without that CBT to see if how necessary that is. And with that, so I'll thank my colleagues and our funding sources, largely so far nonprofit philanthropic foundations. And yeah, thank you for your attention, and I'm happy to take questions.